Hello, I'm Erica Young. I'm one of the Yale Internal Medicine residents. This is the Yale20 presentation on atrial fibrillation. Developed this with Dr. Rachel Lampert in cardiology. So, outline of the presentation, we'll begin with a 5-minute bedside assessment asking how sick is my patient and what is the acute management. We'll discuss the diagnosis and workup, including EKGs, labs, and relevant imaging. We'll then move on to the treatment, including the acute treatment of patients with rapid ventricular rate, long-term treatment, including rate control versus rhythm control and cardioversion, as well as antithrombotic therapy. We'll finish with the assessment and plan with a sample write-up, as well as some take-home points. So, the 5-minute bedside assessment. When called by the ED for atrial fibrillation, there are a few questions that I would begin asking. First, what are their vitals? Are there any signs of shock, heart failure, or ACS? Are they symptomatic, including palpitations, fatigue, dyspnea, lightheadedness, or chest pain? What was the time of onset of their symptoms? What does the ECG look like? Is there any underlying cause? And is the patient on antithrombotic therapy? Based on the responses to those questions, you can then triage the patient. So patients who are hemodynamically unstable, meaning they're hypotensive, should go to the step-down or CCU for IV medications and possibly cardioversion. Patients who are hemodynamically stable, but with a rapid ventricular response, or RVR, can be medicated initially on the floor with IV medications, but may need transfer to the step-down unit. Patients who are hemodynamically stable with a normal heart rate can likely remain on the floor or even be managed as an outpatient with oral medication. The acute management of a patient with AFib with RVR. First, attempt to control the ventricular rate with IV agents. The most common of these are the non-dihydropyridine calcium channel blockers, such as diltiazem and verapamil, as well as beta blockers, such as metoprolol, propranolol, and esmolol. Amiodarone may be preferred in patients with heart failure with a reduced ejection fraction, especially in patients who are acutely decompensated. In general, the goal heart rate is below 110. Below, I've listed some basic dosages of these common medications. So metoprolol, generally begin with 5 milligrams IV push, which can be repeated every 5 minutes for a maximum of 15 milligrams. Diltiazem, I begin with 0.25 mg per kg IV, which usually works out to around 15 to 20 mg over 2 minutes. An additional dose can be given if needed after 15 minutes, and if the patient is still in RVR, I would consider starting a drip of 5 milligrams an hour. The drip can be increased by 5 mg an hour every 10 to 30 minutes, up to a max dose of 15. Patients who are appropriate for an amiodarone drip can be started at 15 mg per minute for 10 minutes, then increased to 1 milligram per minute over 3 hours, and then gradually titrated down to 0.5 mg per minute. What is the acute management of a patient with AFib with RVR? The next step is considering whether the patient is a candidate for early cardioversion. Some common indications are if the patient is hemodynamically unstable or symptomatic, no evidence of thrombus on a transesophageal echocardiogram, and if this is their first episode of AF. Contraindications include plans for long-term antiarrhythmic therapy, patients who are elderly, previously failed cardioversion, have a known thrombus or cannot rule out a thrombus, and the patient is not on antithrombotic therapy, or if you anticipate spontaneous conversion with treatments of an underlying cause. Lastly, I would discuss antithrombotic therapy, as patients who are not already on antithrombotic therapy should be started on a heparin drip to prevent formation of thrombus. Next, we'll discuss the diagnosis. There are several cardiac and extracardiac causes that can contribute to AF. Primary cardiac causes can be divided into structural heart disease, such as left ventricular hypertrophy, valvular disease, hypertrophic cardiomyopathy, a dilated cardiomyopathy, restrictive cardiomyopathy, MI, pericarditis, myocarditis, surgery, particularly cardiothoracic surgery, and other arrhythmias, such as AV-NRT or Wolff-Parkinson-White. There are also several extracardiac causes of AF, including obesity, OSA, excessive alcohol use, pulmonary embolism, and hyperthyroidism. There are several terms that are used to classify AF. First is based on the time period. So permanent means that the patient and the provider agree to not attempt to restore sinus rhythm, meaning that you expect the patient to be in permanent AF. Persistent means that AF has been present continuously for more than 7 days. Long-standing persistent refers to EF that has been present continuously for more than 12 months, and paroxysmal refers to AF that terminates within 7 days. AF can also be classified in terms of valvular or non-valvular disease. Valvular disease is AF that is associated with rheumatic mitral stenosis, a mechanical or bioprosthetic heart valve, or mitral valve repair. Finally, patients are classified as having lone AF if the patient is less than 60 years old and has no underlying heart disease. The inpatient workup includes ECG and telemetry, measurements of electrolytes, CBC, TSH, free T4, and LFTs to evaluate for underlying causes of AF, possibly an echocardiography if this is a new diagnosis of AF, to evaluate for structural causes, a chest x-ray, and possibly a stress test if the patient has other risk factors or other symptoms concerning for ACS. Next, we'll discuss ECG findings in AF. The hallmark of AF is an irregular ventricular rhythm with absence of P waves. Instead, you may see low amplitude oscillations, which are the fibrillatory waves of AF. The QRS complex is usually narrow, meaning less than 120 milliseconds. However, it can be widened if there is other conduction disease present. The first rhythm strip is an example of AF at a normal rate, exhibiting the fibrillatory waves in an irregular ventricular rhythm. The lower strip is an example of AF with RVR. You can see the rate is around 150. Now we'll move on to the long-term treatment of AF, beginning with a discussion of rate or rhythm control. Rate control means that the patient remains in AF and you try to bring their heart rate to below 110. This is generally the goal for most patients, assuming that they're asymptomatic and have normal left ventricular systolic function. Patients who don't meet those criteria may be candidates for even lower heart rates goals. First-line medications, as mentioned previously, are beta blockers and the non-dihydropyridine calcium channel blockers, most commonly metoprolol and diltiazem. Metoprolol tartrate is a BID drug, generally dosed at 25 to 100 milligrams twice a day. And metoprolol succinate, also known as metoprolol XL, is dosed at 50 to 400 milligrams daily. Diltiazem, generally 120 to 360 milligrams total daily, which can be divided based on the formulation of diltiazem. Digitalis is sometimes used in patients with heart failure with a reduced ejection fraction for rate control, though it's becoming less commonly used given its narrow therapeutic window and risk of toxicity. It generally should not be used in conjunction with amiodarone. The other class of medications in treatment for AF attempts to bring the patient in sinus rhythm. First-line medications include sotalol and dofetilide. Amiodarone is more commonly used in patients with LVH and heart failure. but there's a risk of toxicities associated with long-term use. Amiodarone beginning dose is usually 600 to 800 milligrams total daily until reaching 10 grams total, which is referred to the amiodarone load, and then decrease to 120 milligrams per day as a maintenance dose. There's many different dosing schemes that exist and can be personalized to your patient. Your choice of which of these antiarrhythmic medications will largely depend on their comorbidities and how long you expect them to be on the medication. Next, we'll discuss cardioversion. This refers to electrical or pharmacologic methods to restore sinus rhythm. The major risk of AF is embolization of a left atrial thrombus, either during or after cardioversion, which can cause a stroke. Generally, patients are started on antiarrhythmic medications first, and if those are not effective, then they may be a candidate for electrical cardioversion, or DCCV. Management of the thromboembolic risk has a couple different options. If the onset of AF was less than 48 hours ago, then the risk of thrombus is considered to be low, and one can proceed directly with cardioversion. Otherwise, you have two options for minimizing their risk of embolization. The first is to keep them on antithrombotic therapy for 3 to 4 weeks, and the second is a TEE to rule out a thrombus and starting them on a heparin drip afterwards. All patients, regardless of which option is chosen, should be on at least 4 weeks of antithrombotic therapy after cardioversion, again to prevent risk of embolization. Options for pharmacologic cardioversion include IV and oral meds, such as amiodarone and butylide. PO meds include flecainide, propafenone, and dofetilide. The first doses of these are generally given as an inpatient, so that the patient can be monitored on telemetry for any arrhythmias. Electrical cardioversion, or direct current cardioversion, DCCV, is usually more effective than pharmacologic cardioversion, but has the added risk of requiring sedation. There are also several non-pharmacologic treatments for AF, which are somewhat beyond the scope of this course, but just to mention briefly. The first is catheter ablation or surgical ablation, so creating electrical scarring within the heart, either through a percutaneous route, as in catheter ablation, or a surgical approach to block electrical activity within the atria. There are also several left atrial appendage closure devices that aim to minimize the risk of forming a thrombus within the left atrial appendage. These are shown below. Ones that are currently FDA approved for AF include the Lariat and the Watchman. The last piece of the long-term management of atrial fibrillation includes a discussion of the risks and benefits of antithrombotic therapy. The main indication for these is to prevent risk of stroke in patients with AF. First, one would evaluate the patient's risk of having a stroke. One commonly uses what's known as the CHADS-VASc score, which assigns a point for each of the 1 or 2 points for each of the following conditions. So 1 point for CHF or other LV dysfunction, 1 point for hypertension, 2 points for age greater than or equal to 75, 1 point for diabetes, 2 points for prior stroke or TIA, 1 point for vascular disease, 1 point for age 65 to 74, and 1 point for female sex. Stroke risk increases with higher scores, with a score of 1 associated with an annual stroke risk of 0.7%. Most guidelines recommend that patients with a score of 1 or higher should be considered for antithrombotic therapy to minimize their risk of stroke. However, the benefit of antithrombotic therapy in preventing stroke has to be weighed against the risk of bleeding. One score that's been developed to evaluate this risk is called the Has-Bled score, in which 1 point is assigned for hypertension, abnormal renal function, abnormal liver function, stroke, bleeding predisposition, label INRs if the patient's on warfarin, age greater than 65, concomitant use of aspirin or NSAIDs, and alcohol abuse. A total score of 5 is associated with an annual risk of major bleeding of 12% or higher. And the risk of bleeding increases with scores. As with everything in medicine, the risks and benefits of antithrombotic therapy need to be carefully weighed and discussed with the patient. There are several options for antithrombotic therapy. First and most well-studied is warfarin. Benefits, it's cheap, reversible, it's pretty well understood, and can be used in patients with mechanical valves. The main drawback is that it requires frequent blood draws to monitor the INR, and it can be difficult to maintain patients in a therapeutic range based on their diet, other antibiotics, genetics, and so on. A new class of medications that has come out more recently is the novel oral anticoagulants. These include dabigatran, rivaroxaban, and apixaban. So dabigatran is a direct thrombin inhibitor, and rivaroxaban and apixaban are factor Xa inhibitors. The benefits are that they are given in fixed doses and don't require any lab monitoring, and studies have shown that they are non-inferior to warfarin in preventing strokes. However, they are not approved in patients with severe CKD or patients with valvular AF. They're also more expensive, and reversal agents are still in the development phase. The last option available is just aspirin. This is generally used in patients with a low CHADS-VASc score, so 0 to 1, or patients who cannot tolerate warfarin or the other anticoagulant options. And again, just to emphasize, the risks and benefits should be discussed with patients to allow them to participate in decision-making. This is a medication that they'll be on long-term and is associated with significant risk of bleeding. In your assessment and plan for a patient with AF, one would want to specify the type of AF, evaluate for any underlying causes such as structural disease, ischemia, infection, toxic metabolic abnormalities, and hyperthyroidism. It's also a good idea to specify the past, current, and future medical therapies, including whether the patient is on rate or rhythm control, whether they've ever been cardioverted, and if and what type of antithrombotic therapy they are taking. Here is an example. So Mr. B is a 72-year-old man with a history of hypertension, ischemic cardiomyopathy with an EF of 45% on echo from 2 months ago, and permanent AFib on warfarin. He's presenting with palpitations for 1 hour. He had run out of his home metoprolol approximately 5 days ago. In the emergency department, he was normotensive with a ventricular rate of 140. He had an ECG, which showed atrial fibrillation with a rapid ventricular rate. Labs revealed normal electrolytes and normal troponin, and his INR was therapeutic at 2.4. He received diltiazem IV with improvement in his heart rate to the 90s and resolution of his palpitations. So we would say that this patient is in permanent atrial fibrillation, now presenting with RVR in the setting of stopping his metoprolol on warfarin. We can check his TSH if this has not been done recently. We would place the patient on telemetry to monitor his heart rate. For rate control, we would resume his home metoprolol at his home dose of 50 milligrams PO BID. And for antithrombotic therapy, we would continue with his home warfarin at 3 milligrams daily for a goal INR of 2 to 3. To summarize, here are the take-home points from this presentation. So atrial fibrillation is a supraventricular arrhythmia defined by an ECG showing an irregular rhythm and absence of P waves. The acute management of tachycardic patients is based on rate control in order to maintain adequate cardiac output and either initiation or continuation of antithrombotic therapy as soon as possible. Immediate or early cardioversion can be considered for symptomatic patients without contraindications, namely exclusion of a left atrial thrombus. However, the choice of whether cardioversion will be pursued depends on the long-term management plan for the patient. All patients presenting with new atrial fibrillation should be evaluated for underlying causes, including structural, ischemic, metabolic, infectious, and toxic etiologies. The long-term management of patients involves rate or rhythm control and consideration of cardioversion. Lastly, the risks and benefits of long-term antithrombotic therapy must be evaluated and discussed with all patients before coming to a decision. There are several sources available for more information on atrial fibrillation. Braunwald's heart disease, sparktool.com is an excellent website for measuring the stroke and bleeding risk assessment based on the CHAS-VASc and HAS-BLOOD scores. ECG Wave Maven is a site where I got most of the ECGs and also is a wonderful library of ECGs for other arrhythmias that I would encourage you to take a look at. Thank you very much. This is the Yale20 presentation on atrial fibrillation.